Good afternoon or evening, everyone. We'll go ahead and get started. Thanks for joining us. My name is Diane Haddad, and I'm a trauma surgeon at the University of Chicago. On behalf of the AAST Health Economics Committee and the Acute Care Surgery Committee, I would like to welcome you all to our virtual Grand Rounds, where we will be discussing Training the Future ACS Workforce, the economic implications of the second-year fellowship. Please note, AAST no longer offers CME for live Grand Rounds. Should CME be available, for this version, you will receive an email from the AAST to prompt you to log in and claim your CME. Our field of acute care surgery continues to grow in both breadth and popularity. The competitiveness of second-year acute care surgery fellowships continues to rise, with more and more applicants interested in two-year fellowship training spots than ever before, outpacing the number of second-year fellow spots that are available. For the most recent 2022 match, more than 2/3 of the 362 applicants expressed interest in two-year spots, and the 81 available two-year ACS programs had a more than 99% fill rate compared to only 80% for the 271 one-year surgical critical care spots. While the primary goal of any fellowship program is education, we're here today to consider the financial implications of training. Today, we will move beyond the discussion of service versus education and explore the economics of second-year fellowship training. We will aim to understand how training programs utilize their fellows in revenue generation and ask who from the health system benefits from that work. And finally, we will explore the overall cost, benefit, and financial viability of the second-year fellowship to an ACS division, a Department of Surgery, and a health system. This is particularly timely as each of our healthcare systems face mounting financial pressure in the current political climate. There is an increased need to validate the value of our clinical endeavors, as we are often asked to financially justify education programs. Joining me today for a discussion aiming to increase transparency, we have a brilliant group of panelists who will share their center's experiences and highlight their own insights and best practices for maximizing the value of ACS fellowships. But first, I'm honored to introduce as my co-moderator, Dr. Annie Moore, an education icon and ACS and Surgical Critical Care Fellowship Director at the University of New Mexico School of Medicine, to share some early national surgery data on where our field stands.
Thanks so much, Dr. Haddad, and thanks to the AAST for sponsoring this really important panel. Share my screen here.
Do you want me to share it or do you have it?
Yeah, why don't you share?
Let's do it.
All right. So this is a survey that we conducted to obtain some preliminary information on AAST fellow salaries and productivity. Go to the next slide. We conducted both an email survey as well as an in-person survey of the AAST Acute Care Surgery Program Directors Subcommittee at the AAST annual meeting, and again by email. We had 16 respondents, and we can go into the results from those 16 respondents. So specifically asking about the second-year fellows, the fellows who are not ACGME fellows, their average salary from those 16 respondents was $98,000 with a median of $93,000, with a range from $78,000 to $140,000. So pretty broad range and generally slightly above the proportional GME salaries. We then asked if fellows were offered the opportunity to supplement their salaries via moonlighting or call pay, and just over half of the respondents responded that yes, the fellows have the opportunity to increase their salaries through additional opportunities that range from moonlighting at level 3 trauma centers, in-house call pay, or ICU coverage, with a broad range of additional supplementation as low as $500 for an extra call shift, up to $100 an hour, and then up to $2,000 for an overnight shift, with some fellows managing to supplement their salaries with an additional $30,000 per year. We then asked if fellows were eligible for individual salary bonuses based on productivity, and the vast majority of respondents said that no, their fellows do not get additional incentive or bonus pay. We then wanted to know a little bit more about fellows independently generating RVUs, billing as a independent member of the staff, and 90% of the respondents said yes, their fellows do generate independent RVUs. We then asked if the fellows do their own billing, and half said yes, their fellows do their own billing. Of those who said no, most of those programs, the attendings also do not do their independent billing. And of those programs that do have their fellows do their own billing, the majority said that they do teach their fellows this important skill of how to appropriately code and bill their encounters. So I think with this information in context, we can move on to our panel discussion where these panelists can discuss their own individual programs, their experience, and hopefully we'll have a lively and robust discussion. I'll turn it back to Dr. Haddad to introduce our panelists.
Thank you, Dr. Moore. I'm privileged to introduce our four panelists who will be joining us in this discussion today. First, Dr. Niels Martin, the Division Chief and Fellowship Program Director at Penn Trauma. It's a AAST accredited fellowship with 4 two-year AAST spots, 1 emergency medicine surgical critical care spot, and 3 one-year surgical critical care spots. Dr. Steve Gondek is Associate Professor and Fellowship Program Director for the past 4 years at Vanderbilt University Medical Center, a AAST accredited fellowship with now 5 two-year positions. Rachel Choron is the Medical Director of the Shock Trauma ICU and Program Director at the Rutgers Robert Wood Johnson Medical School, a non-AAST accredited fellowship established in 2011 with 2 fellows a year and plans to expand to a third second year fellow. I believe you already applied for this. And then Collin Stewart is the Trauma Medical Director and Associate Program Director at the University of Arizona, a AAST accredited fellowship with 3 fellows annually, which increased from 2 in 2023. And for the first question, I will turn it over to Annie.
All right. I'd love to know from each of you guys, how are your second year fellows paid? Specifically, thoughts on their current salaries and how you finance those salaries, and what additional financial benefits are available to them.
I can start. Our fellows are paid basically out of our practice, from the same pot of money, if you will, that pays for the faculty salaries. So they do not come out of a GME fund or any GME related expense bucket. They are practice related. Now at Penn, our practice and the department's faculty are part of a larger physician group, but that physician group is really where they are based and their salaries come from.
So I'll go next. So here at Vanderbilt, our fellows they're funded a little bit creatively, and so like many institutions, we've exceeded the congressional limits for the number of trainees, ACGME trainees we can have, and probably every institution on this panel has done the same thing. And so what Vanderbilt has decided to do is if you introduce a new residency fellowship or anything, that comes out of your division or your section, depending on some details. And then you pay for your own resident and you decide that that's worth it because you maybe don't have to hire as many nurse practitioners or whatever it is that you're doing it for. And so our instructors are considered to be 60% in one of those pools as GME, and that gets them part of their 60% of a PGY7 salary, plus all the benefits that you would get by being house staff. And then they're 40% considered non-GME, which is an appointed clinical instructor position, just like any other faculty position that comes out of our section. And I keep emphasizing it comes out of the section. We'll talk about this some more later. They do not come out of the same, well, they don't come out of the same direct pool of money as like the trauma faculty. They're considered faculty of the section, and they are not considered for bonus structures and things like that, faculty of the division of trauma or of acute care surgery. But that's how they're funded. That way they get kind of to get the benefits of being faculty and the benefits of being GME.
Our fellows are paid by our health system, the Barnabas Health System, which is a little bit different than the residents and other fellows hired at Rutgers who are paid through GME. Our faculty are interestingly paid by different groups, depending on when you were hired. Historically, it was by the medical school. And then following COVID, there was a new approach that was 90% through the health system. So it varies a little bit across the board, but our fellows are currently hired through the health system. They're hired at a PGY 7 salary base, which we've advocated to try and hire them at the clinical instructor level, which would be a higher salary pay point.
Here in Tucson, the first year fellows are on that ECGME funding, and then the second years are actually paid by Banner Health, like through the system. They're hired through the system through the Banner Medical Group, and so that's where their funding comes from. The way that they're put into kind of different buckets, we can talk about later too when we go to like RVU generations and things. They're not directly part of our group, but they are funded through the hospital. So like a few years ago, when we increased our fellow complement, ACGME took care of that year, finding different ways. There were changes in some of the programs got smaller, so they were able to shift money around for that. But the second year, we had to go with a proposal on how they would, provide value to the system. And just like you're making, like if you want more APPs or anything like that, then you make a proposal and you essentially are taking the funding that the hospital would find valuable so that they can fund it that way.
If I can just make a follow-up statement. So I think there's many of us are describing two things. One is, where does the money actually come from at the end of the line? But then how do you actually, what is the structure by which you pay the fellow? And so our fellows are technically still paid just like any other house staff, meaning that's where their paycheck says it's coming from the Department of Surgery, Division of Surgical Education. It looks like any other house staff member, and that affords them all of the luxuries of being a member of the house staff, right? There's a clear, defined benefits, insurance, all those things. It's exactly like you don't have to redefine it for this group of people. So all of the structure, their malpractice, all of those things goes through GME like anyone else. But at the end of the day, our practice pays the GME office for their expense. But the infrastructure to hire them and to afford them all of the benefits, et cetera, comes through GME. And I think that's probably the easiest way, if I was going to start this afresh somewhere, would be to use the pre-existing infrastructure, right? Use the pre-existing infrastructure that pays house staff otherwise. I think it's also cleaner that way. That system is used to the churn of fellows coming every year, as opposed to saying, well, I'm going to hire them into my practice. And then it potentially could get a lot more kind of messy if you try to hire them and onboard them as like a new faculty member. But every year you're hiring 4 new faculty members or whatever your magic number is, can get a little weird. Whereas the house staff system is built around those cycles.
And along those same lines, and it's the follow-up for all the other panelists. So what about, that's their salary or benefits also something that come out of your individual division? At Penn, you're paying them not only for the salary, but all the other benefits that would meet GME requirements. I'm getting some nods. And I guess my question for the other panelists, does anyone do anything differently at their system? Is it all, or do all the paychecks look like GME paychecks with all the associated benefits? It just pulls from the different pools that you mentioned, the health system or the hospital.
I will say ours currently looks like that, but maybe 4 or 5 years ago, we made the switch from our old system. And in our old system, they were 100% faculty in the division. Their billing still strangely went to the section. We can talk about that separately. But so they were 100% instructors and they had no connection to GME whatsoever. And we've since transitioned to this model. And I agree with Dr. Martin's point that the churn side of this makes it so much easier because even them having some non-GME component ends up generating a lot of paperwork for me and for our staff. But the churn side of it and a lot of the benefits that you don't even think of, like free parking or like access to the gym or like stuff like that, came along with the meal money at night, came along with the GME transition. And so there was a lot of benefit in that. The other interesting thing, while we just talked about that, is when we did that. So it's hard to measure how many RVUs somebody does supervised, right? Because you don't do it that way because it goes to a different person. But prior to that switch, our instructors were doing somewhere on the order of 10 to 12,000 RVUs per year, sometimes a touch more than that. And then when we switched, now they are billing themselves about 5,000 RVUs, and then they're probably the remainder of those 6,000 RVUs are all getting taken by faculty. Pros and cons to that, but that's what happened, just to look at the numbers a little bit. And so they do end up funding themselves with the remaining leftover RVUs, which are random things like the faculty wasn't available to supervise a central line, but the instructor was there and stuff like that. It adds up.
Yeah, awesome. That leads us right into our next kind of topic of conversation. So all of the fellowships represented on this panel have their fellows credentialed as instructors who can independently bill and generate RVUs. So I'll ask our panelists, first of all, how do you ensure adequate autonomy and oversight for your acute care surgery fellows as they move into this role? And at the same time, how is that fellow billing actually captured? Dr. Choron, if you want to start.
Sure. So we have a tiered system of autonomy, tier 1, tier 2, and tier 3. So in tier 1, it's considered direct observation. They're in a little bit more of a traditional fellow role. There's faculty who are the attending billing for cases and admitting under their name, operating under their name. And then following that period of time, which loosely is 3 to 4 months, we do an evaluation of the fellows among the faculty. And if they've met our requirements, we advance them to tier 2, which is indirect observation. During their first year of fellowship, we get them credentialed and onboard them as faculty for the second year. To Dr. Martin's point, this is challenging. That does go through the system, like you're hiring new faculty every year. So it is a little bit burdensome and time consuming. But once we hit tier 2, they take over as the faculty member, and they're paired with an attending on service and in-house at night when they're on call. Faculty still respond to our highest trauma level activations and any patients in shock, and help in the OR if requested for other cases, which is of course encouraged. Tier 3 is fully autonomous. They're on the attending schedule like the rest of us. We're back up from home like you would be at night for other faculty members. So that's a little bit of the structure of our fellowship. And I think, did you ask me about RVUs in this question as well?
Yep, we can hit it. Sorry, I was muted, of course, because I don't.
Sure. So they're really billing for a period of 7 to 8 months or so during the tier 2 and tier 3 portions of the second year. So it seems that they're billing around 4,800 to 5,000 RVUs during that time. If other faculty come in, I think RVUs are getting distributed differently. In our group, our faculty are not RVU based. I think it demonstrates our divisional effort overall. So we do, try and bill appropriately and demonstrate our RVUs for productivity's sake. But no one, there is not a battle for RVUs, say it that way.
And I think Dr. Stewart, your system has a similar tiered fellowship or tiered approach to autonomy and billing for your fellows as well.
Correct. Yeah, we have for the second year fellows, there's levels 1 through 4 where we go through and provide tiered responsibility. And we go, and after the fellows do each of the rotations on trauma, we go back as a group at our faculty meetings, what's happening right now that I'm here, and they're talking about the fellows. And we evaluate whether they can progress on to the next level that gives them more autonomy. A lot of that then goes into what they can do. Now, because of the way that our system is set up here and the RVUs get allocated, the fellows whenever they make RVUs, they just go to the hospital and don't actually go to our division. And while we are now shift based without a specific RVU target, even though they give us one, and anyone would be foolish to think that the hospital doesn't look at your productivity to track what you're doing. To be able to ensure that faculty are meeting those metrics anyway, a lot of it goes into the attendings on the bottom line, but based on the tier that they're on, they, you pop your head in, you're like, yep, that looks like you're taking out an appy, and you walk out, and you leave it up to the individual faculty to determine what is the critical portion of something. The other way we have the fellows generate RVUs is that because they are credentialed as part of the staff, whenever we do cases with them, they are the assistant surgeons, and so they also generate some RVUs, even though it's a small portion of each case. That also provides a small number of RVUs for every case that they do that we are really intimately involved with as well. If we've been in discussions off and on about trying to get their RVUs to come into the pod of the division as opposed to just going to the hospital. That was whenever the initial agreement came with Banner Health, that they would fund the second year fellows, that they would pay for their own salary through RVU generation. That's why it was set up that way. And I think there would be a little bit more of a let go with the RVUs, since they just kind of go into the ether whenever a fellow bills for it. But that's kind of the system that we have. We also try to prioritize in that same vein. Every attending obviously has different comfort in letting go. And so as they progress through those levels to a higher tier of more autonomy, we try to ensure that there is adherence to our faculty and allowing the fellows, even though you're there to help out, really still let go and let them really be autonomous.
Dr. Gondek, similarly curious how you balance this autonomy and oversight, and then specifically, I think, to your unique RVU generation system, if you want to speak a little bit about that with your fellows and the faculty. I know you hinted at this before.
Yeah, so sure. So it's somewhat similar to what Dr. Stewart was just describing, where basically if an instructor bills something and it's not supervised by faculty, it also goes into the ether. It goes to the section, and that does pay for their instructor salary and those kinds of things. It's interesting. We've moved recently we've always been a group productivity model, but they finally defined it very clearly for us here. And so I can tell you, per RVU, what does the group get over our goal, which is useful. And that has put a little bit more emphasis on we need to be generating RVUs because the faculty compensation is directly affected by it, which is good for getting things done and good for keeping us busy and encouraging the people who work hard to continue to work hard. But as we're all alluding to, it's not good for instructors. And what I've been finding is I don't think it's as big of an issue as we make it out to be. I used to really push on this, to try to separate those things. And what I'm finding is what really defines how independent the instructors can be is the experience of the faculty and training the junior faculty to get used to how to do that in a good way. Because just as much as the instructors want their independence, they also want to learn from the faculty at the institution to which they went to fellowship. And so there is benefit in having, our senior most faculty in the OR with them for certain things. And there also is benefit for them, feeling a little uncomfortable being alone for some other things. But we do a couple of funny things with our schedule to try to address that. And like a good example of that is early in the year, the first 2 months of in-house proctoring, we call it, for the instructors, the faculty that do that are required to be at least 2 to 3 years out from training, just so that they've really had a chance to get their feet under them and they're comfortable. And they are less worried about coming up an M&M or something like that. And so I think mechanisms like that are probably more important. And I don't think many trauma systems have a huge reliance on productivity for their compensation. Like ours is 5 to 10% of our salary. It's not a huge difference.
Dr. Martin, I see you smiling. Do you want to weigh in?
Yeah, just briefly, I agree with all the models that have been described. If a division is paying for the salaries, then the division should theoretically then keep those RVUs. And that's the model that we have. Within the division, we do use a group metric for RVUs. So it's not individual based. And what that does then is it really doesn't matter who bills for the case as long as someone in the room is billing for the case. And so that allows, like, it doesn't matter who ultimately signs the op note, because it all goes into the same pot. So it allows then for the direction of that room to really go into what is most educationally valuable for the fellows. And so that's really when we think about our onboarding process and even the support throughout the rest of the year, it's much more about the fellows' education, and it really doesn't matter who is the ultimate attending of record, do the RVUs go under. I mean, of course, we track everyone's RVUs internally, but in terms of how we're viewed by our department and how we view ourselves in terms of our incentives, it's a group metric. And that really minimizes then any interference financially over the educational environment.
You guys have, in one way or another, all hinted at the number of RVUs that your fellows generate based on independence, based on availability. But when you think about how your department leadership perceives your fellowship and the financial viability of your fellowship, how easy or hard is it for you to make that case that investing in your fellows' salaries, either at the division level or the health system level, is financially viable?
Well, maybe I'll start. You frame what you say dependent upon your audience while still being fair and realizing that things can be transparent across the board. But if I'm talking to my department's CFO, I'm going to tell my department's CFO that the fellows actually bill almost better than some faculty and yet cost us less. But when I talk to the fellows and fellow candidates, I will tell you that, listen, you're going to work and we're going to bill for you, and that keeps the lights on, but you're here for an educational experience, and I promise you that you're going to receive the educational experience that you are looking for. So everyone gets what they want. The fellows get exactly what they want in an educational experience, and that's something that we protect dearly. And our CFO gets what they want. And so we tell everyone what they need. And if they were to understand both sides of the curtain and look at each other's metrics, I think they'd probably still be happy. But I think you have to really tell people what they need to hear to be happy with what you're providing. And there is a balance, right? Like, financially it works and educationally it works. And as a group and as an institution, yes, we like to make money, but we have this real educational mission that brings value to the work that we do every day. And I feel like we accomplish both things well. And that's what I think makes us all, academic institutions.
And I think the rest of you are either in the process of applying for an additional fellow spot or have done so in the recent years. How did those conversations go, or how did you navigate having that conversation about financial viability?
Yeah, I mean, I think what Niels said is entirely true. It depends on the person that you're talking to. If you increase your fellowship, you got to get through the AC or the GME office. You got to talk to the people who handle the money. So you don't go to the GME office and say, I need more people because I need more people to work. And they're like, well, that's not what they're there for. Like, if you want to get something shot down quick, you tell the GME office that you need manpower. Like, they do not want that. They want that you're providing education and everything like that. Then you go to the people with the money. Like, what we did is we were like, all right, here's the RVUs that they generate. And now they rotate at our level 3 hospital. It's down the road, so that they are independent there. So they are fully generating there. They're filling a spot that someone that's paid much more than them, they get paid like $900 a shift. And we as full attendings get paid more than that for those shifts at that hospital. And then you sit there and you say, all right, you are a large healthcare system that has a number of trauma centers, a couple level 1s, level 2s. And you can look and say, we're like, look, we have hired like 3 fellows here, and another one of our fellows went to your other hospital here. And I mean, that costs a lot of money. And if they're retaining their fellows as well, it's not just the money at the bottom line, but also showing that you are providing a pipeline for recruitment as well. And I think whenever you pull all those different things together, that's the conversation that you have to have. But you definitely have to tailor which group you're talking to and really point out the different aspects of it.
I'll say we got kind of either lucky or intentional about our timing of adding another fellow slash instructor, and the institution desperately needs right now more intensivists. And so as across the country, right, as anesthesia critical care has been not recruiting as well, and people are coming out of that specialty, we also at the same time built an entire new critical care tower with 5 ICUs in it. And so the institution heard the idea that we might even be able to add one fellow and was like, let us help you figure out how to make this work. And then we also are, from the way we are doing it, the amount that they're billing, if you just extrapolate that and divide it by one extra person and stuff, was enough to still cover their salary without losing money. And so all those things just lined up. I will say, to Niels' point, they've asked us if we would expand more, and we've said no, because we also have an educational mission, which is what he was talking about, where my feeling is we can't dilute the education by one more fellow. I think we're at a good number now, and it was beneficial. That would be too many. And so that was a really important factor in it also. And I think our GME offices kind of liked to hear us say that. I think that gave them a good taste in their mouth about what we were trying to do.
Great. And the last, we'll wrap up thinking about RVUs and thinking about fellows. One, do your fellows ever get feedback on the number of RVUs that they generate or how well they're billing? And on top of that, do they ever get any financial bonuses with your group related to those RVUs that they generate?
I can kick that off. Unfortunately, our fellows really do not receive bonuses. They have a flat salary similar to the attendings, which I think the structure is similar because of that. And I think that's an opportunity for bonuses, especially in the setting of the RVU generation. So that's something that we're trying to advocate for. Just touching back on that last question, I kind of echo everything the other panelists said. We also just put together a proposal and sent it to our CFO regarding an expansion. And so a lot of the language, again, was more specific to the finances and less specific to the educational mission because of that. I think helping to explain the acute care surgery model briefly, succinctly, but to give them an idea of the 7 service lines covering 2 hospitals 24/7 with only 12 faculty members also, I think, helps emphasize the need. And then here's this option that, is an RVU generating faculty member at a different pay point. So, taking that strategy hopefully will be effective for us. I think the other thing that we considered was Rutgers luckily is a huge system with many GME programs, many programs within the GME, and looking to see what proposals have been successful before and what they looked like, and finding elements that were specific to Rutgers that what they were looking for.
I'd love to know how, when you are proposing these changes to your institution, how transparent are you about this with your fellows? Are you teaching your fellows about how to justify their existence? Do you think it's important that they know these skills of what is an RVU? How are you generating them? Are you teaching them billing? Are you teaching them financial responsibility of running a fellowship, running a division?
Yeah, so we do. We don't necessarily give them back their RVU metrics, but we definitely review their clinical documentation. We have a kind of a revenue optimization committee that will give the fellows feedback. We'll look at their, trauma bay notes and their ICU notes and various things that they document and kind of optimize and teach them, like, what are the elements that are involved. What's the difference between a level 1 and a level 3, and why do we always harp on a review of systems? And so yes, we definitely teach our fellows that. We have a couple didactic sessions throughout the year that focus, and that's not just for the fellows but also for the faculty, that reviews all these things, so that as junior faculty members they actually understand how the system works around them. And I do think that that's an important part of their kind of learning and expectations as junior faculty. So they do get that level of feedback. And then just to answer the other question that was pending, we our fellows fall under our union, and our union controls all things when it comes to finance, reimbursement, payments, bonuses, whatever. So if you have a union, even second year fellows in this role, at least at our institution, fall under the auspices of the union. And so there are lots of
Yeah, here, from the Banner Health standpoint, it's just a policy across the board that clinical instructors don't get productivity bonuses. However, like I said, whenever they go to our level 3, they do get paid. We were going to try to do it, and then the hospital system was like, well, if they take those shifts and they're down there by themselves, they have to get paid. And we're like, sounds great. Like, no fellow's going to turn down money for doing shifts. But it's also nice, and they get a lot of feedback at the beginning of the year. I sit down with the fellows, go through what an actual like tending attestation looks like. I'll pull up some of my partners. I'll be like, maybe you don't do it this way, because don't go to the bottom of the note and just say I agree, because you're not going to get like anything for it. Like, what you have to say, do your ICU billing, make sure you go through all those things, and then they get to go down to the other campus. They're by themselves. The residents are sending them notes of various quality, and then every time they go down there the first time, you get a lot of phone calls, and you're like, oh my gosh, like, what do I do? And it's a good learning experience where they're not at their actual job where it really matters, and they still get to learn, but they get to feel the stress of having to sign notes, be on time, and get those things done. Even though they don't get the RVU bonus, they still get the stress and the learning that comes with that of actually signing notes in a meaningful way.
The competitiveness of these 2-year fellowships is really increasing, with more and more applicants every year opting for 2-year fellowships. For programs who are looking at starting a second-year ACS fellowship, adding onto their critical care fellowship, or developing their own 2-year fellowship, how would you recommend that folks engage with their institutional leadership in these discussions?
So I'll jump on that from our recent expansion. Honestly, the couple of things that I found the most beneficial are money, right? And that's going to be the first question: is how much are we going to gain or lose on this? And different institutions are going to tolerate different numbers on that. For me, we had to be profitable, and that they were willing to help us figure out how to make that happen, but we had to be profitable. We couldn't be a net loss of $60,000 a year. And so that's one. Two, though, that we've had a lot of good success with is safety. And if you can point out that having a fully trained general surgeon intensivist that's going to be taking shifts that were otherwise not covered, didn't exist, or something along those lines, and roaming the hospital, it only takes one salvaged airway lawsuit to pay for all of your instructors for the next 10 years. And we point that out a lot, that they are providing direct feedback and supervision to residents, and that they're mentors to the residents, and they're around, and they do get called for emergencies that the person seeing the patient isn't comfortable calling the attending, even though they should be, and is like, I need somebody because something isn't right here, and they're right there. And so I found those to be the most productive avenues to go down.
Any other folks have recommendations? Dr. Choron?
Absolutely. I think, what we've been talking a lot about is the balance between demonstrating educational value, financial sustainability, and then I think also the clinical need can help engage people. So something we started doing for this effort was documenting our census every day, which is often hard to capture in Epic, actually. So at the beginning of morning report, we just go through each service line and say how many consults, how many admissions, and what the census is. And so now we have a pretty good demonstration of how many patients we're really seeing in each 24-hour period and over the course of months, which has increased over time. And so demonstrating that increased clinical need has also helped to advocate for this.
Yeah, I mean, I think if you're trying to start a program, I think what's coming from all this is you really, from the financial standpoint, you have to look and see what your hospital system needs, because that's what's going to speak to them. And there can be the straight X's and O's, pluses and minuses of money that you can say they generate this, but then also being creative and doing things like, oh, it can help prevent complications. Oh, maybe they'll help lengthen shortness of stay. Like we did with saying like, this is going to save you money with like recruitment and things like that, and look and see what your system actually values, because only the people there in it know, and you can feel out what you think is important to them and what is going to speak to them. Obviously, like I said, there's the numbers at the bottom of the spreadsheet, but then getting creative and finding other ways that boost what the product that you're presenting is worth.
Yeah, I think it goes without saying that the first thing you really need to make sure is that you have educational substrate and you have a willingness of the institution to educate fellows. And then once you have that piece, then you say, okay, well, now how do we pay for it? And I think one of the natural things is either you have a clinical expansion that's occurring where you need more faculty or you need to replace a faculty member. But again, I think that's the most natural moment in time where you say, okay, we can hire a faculty member or we can hire one or two fellows to do, to work up to that level of work. And again, it'll be a fair trade and everyone gets what they want. But I think the justification for the cost of the fellow has to be that there's either some type of growth or a replacement of a faculty member that gets supplanted by a fellow or two.
I think that concept is so interesting, like not only value from a surgical productivity standpoint, but like surgical rescue, as Dr. Gondek highlighted, which is such an important part of our role in the hospital as being the people who are like wandering around overnight. And then interestingly, this idea of like, what does the institution need? Is it better to hire a fellow than to hire faculty members? It's different. It's a different investment, but balancing that, I think it's a really interesting topic. And I think along those same lines, right, there's mounting financial pressures, there's change in trauma volumes, there's change in fellowship numbers as our health systems continue to expand despite mounting kind of financial pressures. My question for all of you is, how do you think that second year fellowships should evolve? Where should we be moving? What changes should we be making as we think about the changing landscape?
I mean, I'm a very staunch advocate of my fellows, as any of them will ever tell you. And so I have a very clear vision of what I think is educationally necessary and valuable in that fellowship year. And I'm very protective of their time above and beyond that. We, as one example, in our ICUs, we have a very defined number of calls that we think our fellows need to do from the education standpoint. And if there are gaps, then there are gaps. And those gaps are filled by the hospital with moonlighting opportunities, which our fellows often are the ones to fill them. But we have very clearly defined what is educationally necessary. And I think it's a very slippery slope for a training program to start adjusting what the fellows do based on market stressors, if you will. So I think you have to be very protective of that experience.
Yeah, I agree. I mean, I think we have to keep the fellows and why they're doing a fellowship in mind. They're not doing it to make our work easier. They're not there to make our bottom line work out the way it is. They're here to learn, and you have to continue to balance it. I think it's been good to through the AAST like fellowship program that there's been an emphasis on trying to find this like tiered responsibility so that you're not there. I think in the past there have been issues where people were doing a second year fellowship really separate from the AAST fellowship, and you're essentially an underpaid attending. And that's what we need to avoid. If you're going to go out and you're just going to be on your own all the time, well, you might as well not be underpaid. If you're going to learn on the job, you can learn on the job as an attending. And so really trying to thread that needle and, adjust to the world that we live in, but also remember that they're giving up another year of their life to train, and they should be learning, and there should be something that they come out at the end and say, I'm a better surgeon, I'm a better intensivist at the end of this, so that they weren't just delaying life again without some benefit at the end.
Yeah, I would emphasize what you just said, which, we have to acknowledge that we are costing these people both a year of their lives and a minimum of $250,000 of deferred salary at the beginning of their career, when they often have $400,000 of medical debt that they haven't touched in residency. And those numbers, when you expand them out to the time they retire, become really big. So this needs to be worth it. And so, to both of the panelists' point, like, that has to be on the radar all the time. Now, I do think in the future, as the AAST fellowships develop, we're seeing more and more divergence in what the products of different fellowships are. And that is great, because the product of one fellowship may be the person who is at the more rural level 1 who has to take care of everything. Whereas, the product for like my fellows, they're not going to be as good at that diverse breadth of general surgery, but they're going to be very good at the complex EGS and trauma that we see a lot of here. And I think that has value also. But each individual fellowship needs to look at its material and say, what is it that I'm going to offer these people that are doing this that's going to make this worth that amount of time and that amount of money, and accelerate their career enough at the early portion of their career to catch them back up to what they missed in that year.
Really
I
excellent
think
points. Sorry, go ahead.
I think one of the things that I'm really passionate about is having our fellows come out polished and ready to take on their first job, their first real job. And I think there's a lot more beyond, the clinical aspects, the surgical aspects, the curriculum. So I think having the full 360 package of experiencing hospital QI, meetings, participating in those processes, also participating in hospital committees. I think really getting an appreciation for what being an attending is like, and navigating different pathways of what you can choose as a niche in acute care surgery and in a hospital is exposure, I think, is really important to give our fellows. I'd say the thing that we're personally adding and trying to navigate how to do that in the second year of fellowship without minimizing their current experience and trying to incorporate this as robotics. That's not something that our fellows are credentialed as faculty for currently. And so how to integrate that is a whole nother webinar, most likely. But I think it's probably something for the future that is going to become much more expected.
There's so many opportunities in that second year for professional growth and development. There's a great question in the Q&A that I'm going to jump into that really segues nicely off of that, about the conversation of value of fellows to an institution, especially when compared to the cost of hiring new faculty. But are we actually setting up a national environment for the next decade to have a surplus of fellows who have done 2 years and want acute care surgery jobs at academic centers that are then exceedingly scarce and unavailable? I'm wondering what the panelists' thoughts are on the future of jobs in this specialty.
So I'll say one thing about that. I think that's a very good point. And we haven't run it, at least in my experience, we haven't run into situations yet where fellows are having a difficult time finding jobs. I will say one interesting thing that I've noticed here at Vanderbilt, and probably at most academic institutions, is we lose about 1/2 to 3/4 of an FTE a year to people getting promoted into new roles or progression or things like that without losing anybody, right? And it's just, we have the same faculty next year, and now we're down 1/2 an FTE. If you expand that out to the number of academic trauma centers that there are, I would think that that would absorb all of the fellows that we can produce. But it's a fair point that at some point that we will exceed that number.
Yeah, I think that's a little bit of a hot topic that a couple of our different societies are trying to answer, and that is, what is the market for an acute care surgeon? And there's so many moving parts because it's not just trauma centers. There are a lot of folks who consider themselves acute care surgeons who do EGS and critical care at a non-trauma center, and a lot of our practices may staff a trauma center, but then also staff an adjacent health system hospital that may not be a trauma center. And we're providing EGS and critical care in those realms. So really understanding what is the greater market for acute care surgeons, how many do we really need? I think is a $1 million question that I think a couple of our societies are going to try to answer over the next little while. That being said, and again, I think, you've heard from Vanderbilt, now you're going to hear from Penn, like, yeah, our fellows have been fine in getting jobs. I don't know if that's representative of the larger market. I do still think it is. I think that there continue to be available jobs, but at some point, could the market saturate if we create too many fellowship spots? Will that happen? It has not happened for surgical critical care, despite the fact that we've had more training spots than applicants for 2 decades. But will that happen for trauma? I don't know. I also find that we are seeing a change in who the applicants are for the fellowships. And there are some people out there who are literally applying and saying, I want to do 2 years, but I want to become EGS focused, not trauma. And I think we as a profession and as a society professional society and the AAST also need to embrace those types of trainees and future colleagues. So I don't think anyone can really fully answer the question at hand, but I think it's something we as a profession need to be thinking about, for sure.
Yeah, and I would say too, I think the way to tackle that too is just making sure that you're making a good product. Like, you want a well-trained surgeon coming out of your fellowship. We have fellows that stay in academics, go to large level 1 trauma centers. We have people who go to a level 2, more of a community type practice. But I think if you do a good job in making a well-rounded critical care and acute care surgeon, then they'll find the job that fits them. And there's benefits to what you gain from the 2-year fellowship to my fellow that is at a level 2 out there. He can help improve that system, and he feels, prepared to go out there and hit the ground running as much as the person who goes to a big academic level 1 trauma center. But if you just have a good product, a good educational environment, and they come out well prepared for whatever job, I think they will find what they need, but it can't just be, I think we could saturate the market if we're trying to say everyone that does these needs to stay in something academic or whatever. But I think there's value in whatever job they choose. So.
I'll make one more comment on that topic, and that is that general surgery is evolving. Whether we like it or not, and I was for many years a staunch defender of general surgery because we're all general surgeons, but the training process and who general surgeons are today is very different than who they were 10 years ago and certainly 20 years ago. And so I'm not saying that every fellow who does 2 years actually even wants to go into a heavy academic level 1 trauma center program. I think in some way, the 2-year fellowship is just the evolution of what general surgery training requires now if you're going to become an acute care surgeon, even if that means you're going to become an acute care surgeon at a non-trauma center or at a level 2 trauma center, or you're just going to do EGS or what have you, that in some ways, slowly, the 2-year fellowship is still kind of becoming a necessity or part of that process, at least, because of how general surgery training has evolved. And I think that's something that we just have to be cognizant of. I think the original vision of the acute care training program for the AAST was to train the level 1 trauma center trauma surgeons in academia. But the world of general surgery is evolving, and I think that the focus and the candidates for these training programs are much broader than even 10 years ago.
Awesome. Thank you all. Looking at some other questions from the audience, I'm going to combine these two. Are there any rules around what fellows are and are not allowed to bill for? This concept of they are in training, learning to do something, and at the same time they cannot bill for that. And that's kind of the overlap between general surgery and trauma training and some of the distinctions there. And at the same time is, can you guys comment if any of you during your practice, during the fellowship, allow fellows to do elective cases and how that process plays out?
I mean, for us, there's not a limit on what they can bill. I think part of that comes from first year they're GME, second year they're clinical instructors, fully credentialed, members of the hospital staff, and so they can bill for what they are credentialed for. They don't do elective cases on their own. They'll do a lot of the elective cases that I find in my clinic that I can actually find good candidates to operate on through the way my clinic works, but they don't have their own clinic.
We do let our fellows, if they are in clinic, pick up an elective case that shows up. It's not huge volumes, but we do allow our fellows to do that. And those RVUs go into the same pot as everything else. In terms of rules, there's no real specific rules over what a fellow can and cannot do. Trauma theoretically in most hospitals' credentialing committees falls under the category of general surgery. And so with the general surgery credential, they can take trauma call. Now, medical legally, what do you really allow them to do by themselves, or really educationally, what are the call triggers that they must include a faculty member with? I think is the bigger question. We certainly have the cases where we expect our fellows to call us and at least discuss, if not have someone come in and work with them on a challenging case. And we have a list of what those look like. So, but those are educational call triggers, not financial call triggers.
We are about to hit the hour, but just got two questions that I think are appropriate to kind of wrap up this discussion. But they both essentially center around the opportunity cost of doing a 2-year fellowship versus a 1-year fellowship, and basically asking, and I think this has been referenced by a couple different people, to quote Dr. Gondek's, at least $250,000 cost that the fellow is giving up by doing the process. How do you think, what do you think the benefit is, not only to trainees, predominantly with education being what we're about, and how does that play into the paradigm of general surgery training that we're all facing? Because clearly there is a lot of interest across the board for this 2nd-year fellowship in education.
I think it's the responsibility of the program director, the GME, to ensure that it's a robust educational experience and ensure that you have, the best curriculum and resources you can have for the fellows. And so I think establishing that is what makes the fellowship worthwhile and gives the fellows an experience that lets them become the best attending possible in their first year out.
Second that for sure. And I think that is a big responsibility of the program director and the program to make sure that it's worth it. I also, I've thought about this a lot. This is a hard question because you're not getting new privileges that you wouldn't be allowed to have by doing this fellowship, right? If you do critical care, you can do all the intensive care stuff. And then most committees would allow a general surgeon to take trauma call at most hospitals. My thought is that our fellows get probably a 2 to 3 year head start. And if you look at the volume of cases they're doing, that's similar. So they're probably 2 to 3 years ahead of somebody who only does 1 year. And then in their first 2 to 3 years of being and attending on faculty somewhere, they are developing their academic career where they already have tried some stuff as an instructor and decided if that's a route they want to go down or not. And so they're more efficient on the academic side too. And I would wager that probably gets them a 3 year, 4 year head start, something like that. I'll also add that this year is the first year at Vanderbilt, and this is not true everywhere, but we would not credential you to take trauma call or EGS call if you did not do a 2-year fellowship, period. And so that is starting to happen. And we pushed for that because I strongly believe in the product that we and the other 2-year fellowships are producing. And so it wouldn't make sense for us to hire somebody who was not that product. And when we talked about that at the PD's meetings, you know, a lot of people are like, it's not in writing, but we wouldn't hire somebody who was a 1-year. And so I think when you're looking certainly at really big trauma centers, those jobs are not going to be available to people with 1 year.
Excellent. Well, I want to thank all of our panelists for a very vigorous and robust discussion, framing our second-year fellowships as important value adds across our institutions in the AAST and our education. And thank you to all our participants for attending today's grand rounds. There are sign-in sheets from the AAST. If you submit it by November 7th, you have the potential to get credit if that happens. But thank you to everyone, especially our panelists, and everyone have a great night.